name's Sheila. I'm an ST6 in rheumatology, but I'm currently out of program doing a clinical research and PhD fellowship. So I thought probably what we could maybe learn most from today is what sort of conditions you can see in rheumatology on the acute take, and kind of common pitfalls that you can come across in your stage of training as a SHO reviewing these patients in acute medicine. So the objectives, as I've said, is to go through examples of some common rheumatological conditions that you'll see on the acute take. And then I'd like to highlight some red flags to consider when reviewing patients with rheumatological disease on the acute take. So we'll go through several case presentations and then just briefly talk on the important points after the case. So our first case is a 65-year-old lady who was brought in by an ambulance to ED and had difficulty mobilizing with a swollen left knee. She lives alone, she's independent of her ADLs, she has a history of rheumatoid arthritis, hypertension, and fibromyalgia. And in terms of her medication history, what you can see on the GP record is that she's on amlodipine and amitriptyline. So we examine her and she has a temperature of 36.8 degrees centigrade, so she's not pyrexial. She had an effusion in her left knee, which wasn't very sort of hot and your typical acute hot joint. And she had no synovitis in other joints, but she did say that she was really struggling to mobilize, and therefore the orthopedics team were called in. Her white cell count was marginally raised at 14.2 with neutrophils of 90%, and she had raised inflammatory markers. CRP was 32, ESR was 48. So at this point, is there anything further that you think you might want to know from this lady? If you just quickly type in the chat box, we can be quick in the interest of time. What else in the history would you like to know? Just salient points. Right. Okay, whether she is history of trauma, whether she's weight bearing, those are all the right questions to ask. So she does have rheumatoid arthritis. She's never had gout. She has had previous effusions with her flare-ups. She didn't have a fever. We checked that in ED when she came in, and there was no history of trauma. So one important question that we would need to ask in this lady is what other treatments she's on for her rheumatoid arthritis. You've seen on the GP record that she's on amlodipine, but we don't know what she's having for her RA, which clearly seems to be active. So she was on a medication called Humira, which you might have seen on in your rheumatology patients or patients with IBD. And she was having this every fortnight along with methotrexate. Now, one thing to be aware of in these patients is patients who are on biologic treatments is not always put into the GP record, because these medications will be on their clinic letters from rheumatology, but not on the GP record. So it's always important just to ask these extra questions. So she was on Humira. That was the missing point. And she was then seen by orthopedics, who said to her, you have a flare-up of your arthritis. This is not in keeping with septic arthritis, and sent her home. Now, the next day, she rang up the rheumatology secretaries complaining that she was really struggling and she couldn't still walk. And we advised her to come into clinic where we aspirated her joint, and she had very thick synovial fluid that was green in color. Inflammatory markers were still raised at this point. So if you go on to just, you can take up, just open your cameras, and that, what is it called? QR code. Yeah, so just the QR code should come up and take you to slido.com. We'll just do a little poll on some of the questions I've set up on the slido.poll chat. And the code that you'll use is that 3764757. So the next question is, I hope you've all got the code so I can move on. I can see some of you voting, so I'll assume most of you have the code. So what would you do at this stage? Would you treat her as a flare of rheumatoid arthritis and give her steroids? Would you send a sample off for gram stain and culture? Or would you start antibiotics for septic arthritis? So majority of you have said you would send a sample off for gram stain and culture. That's about 60% of you. Brilliant. About 23% of you would start antibiotics. And, 70% will send a gram stain. 17% will start antibiotics. And 10% would treat as an RA flare. Okay, so I'll just close that poll now. Okay, great. So what did we do? So we requested a gram stain, which was negative. We started IV antibiotics for suspected septic arthritis. Now, this is the thing. It's correct in saying that you need to send off a sample, but if you're suspecting an infection in that joint and having seen the green turbid fluid, we'd normally advise you to start antibiotics straight away. There's no reason why you should delay the starting antibiotics. As long as you've obtained the sample, that shouldn't change your results. So one of the quickest things to do in ED or in the AMU setting is to send off a sample and ask for a gram stain. Gram stains sometimes come back negative, even with positive cultures, but that can kind of give you a quicker turnaround in terms of getting results within 24 hours to say if it's a septic arthritis or not. So we started IV antibiotics and we sent off a sample for culture to our local laboratory, which surprisingly came back negative. We were quite convinced from the clinical presentation and the appearance of the fluid that she did have a septic arthritis. So what did we do next? We thought, okay, in patients who are on immunosuppressive treatments, they can sometimes have atypical presentations. They're not always going to mount a response like a normal patient would. The fact that she's on a biologic might suppress her immune response, and therefore she might not have a typical culture result on the synovial fluid aspirate. So we sent off a sample for a special genetic testing, which is done in London, to look for sequencing for bacteriology in specimens. And this came back showing that she was Staph aureus positive. So she had a septic arthritis with Staph aureus. So we treated her for that. And after 2 weeks, she got better with antibiotics, IV, and was discharged home to complete a further course of oral antibiotics. So I'll just briefly touch on the current RA therapies that we tend to use and you might come across in your assessment of patients. So you know the conventional DMARDs, methotrexate, hydroxychloroquine, sulfasalazine, and leflunomide, but we also have biological DMARDs, which are the, on the next slide, which are the ones licensed for conditions like rheumatoid arthritis, psoriatic arthritis, and spondyloarthritis. So you will come across medications like Enbrel, Humira, Cimzia, tocilizumab, and these are all the medications we use in our rheumatology patients. And the important thing in a patient who comes in with a hot swollen joint on biologic treatment, yes, it could be a flare-up of their rheumatoid arthritis, but it's not always the case. You take a proper history, find out if it's a subacute presentation, or if it's very rapid onset of inflammation in the joint, or if it's been there for a few weeks. If there's any infections in the background that could have precipitated this, and find out what medications they're on. I cannot stress this enough. Find out what medications they take. If you're not sure, speak to a rheumatology colleague. Now, the normal findings of septic arthritis, like you've seen in our patient, may be absent. She had a negative routine culture, but on extended culture, she had an evidence of infection. And they might have a minimally raised inflammatory response in the absence of systemic signs because they're immunosuppressed. So remember also patients on this medication, tocilizumab, which you've now come across having used it for COVID, they will, in some situations, have a normal CRP with sepsis because that's how the medication works, by suppressing IL-6. So the CRP might not always be raised. So you have to have a very high clinical index of suspicion for these patients on immunosuppressive treatment. And again, consider joint aspiration in all cases. Don't see a patient in ED, say it's a flare-up of your inflammation and you've not stuck a needle in the joint. If you can't do it, ask for orthopedics assistance, ask for rheumatology help, because you might be sending somebody home with a septic joint. And in this case, this is kind of a specialist test that we sent off, but if there's a high clinical suspicion and routine tests come back negative, always think outside the box because there's more that you can do to identify a diagnosis that might otherwise be missed. So I thought I'd just show you a few patterns of joint involvement, so you can kind of just know how to describe these when you see them on the acute take. So on the left-hand side or the fingers, what sort of pattern do you think you'd call that? We just quickly type into the chat box. Right, so I cannot see the chat box. I will rely on either Joseph or anybody who's moderating to tell me if there's any answers in the chat box.
Yeah, I can see the chat box, and at the moment, people seem to be typing. No answers yet.
Well, I've put the answer up now.
Okay.
Right, so on the top bit is polyarthritis. So polyarthritis is basically having 5 or more joints inflamed. So in this patient, you can see on the PIPJs, there's a lot of inflammation. There's some inflammation along the DIPJs as well. And monoarthritis is having 1 joint involved, and oligoarthritis is when you have less than 5 joints, but more than 1 joint inflamed. And what do you think you call this? Does anybody have any clue? I'll start you off by telling you it's like sausage-like fingers. Can anybody type in the chat box? Nothing.
Sclerodactyly?
No, so this is what we call
Dactylitis?
dactylitis. Was there dactylitis?
Yeah.
Yeah, so this is what we call dactylitis. So with dactylitis, you're basically looking for inflammation in all three joints. So you could see the MCPJ there looks swollen, the PIPJ there looks swollen, and then the DIPJ again is slightly swollen. So it's usually the entire finger swollen, looks a bit like a sausage. And this brings me to my next question. What conditions do you think are associated with dactylitis? So I will activate the poll. So if you go back onto that poll and just use the same code. Yeah, so we've got a majority of people saying psoriatic arthritis. We've got a few on post-salmonella. We've got some on rheumatoid. Yeah, okay, so I think majority of you are correct. So psoriatic arthritis, you can get this in sarcoidosis, and you can get this in a post-infective reactive arthritis. So dactylitis, it tends to be associated with what we call the HLA-B27 spondyloarthropathies. So things like angstbond, psoriatic or reactive arthritis. You can also get it in patients who have IBD. Things like ulcerative colitis and Crohn's disease can have inflammatory arthritis associated with that. You can get it in sarcoid or sickle cell. Right, so moving on to our second case, we have a 67-year-old woman with rheumatoid arthritis, and she's stable. Her disease has been well controlled over the years. She's on methotrexate monotherapy for the last 10 years, and she's come in unwell with a fever. Her white cell count is 11.5, her neutrophils are normal, and her CRP is 22. A urine dipstick is positive for UTI, and so she started on some antibiotics. She feels better and she goes home, and 5 days later, she comes back with a fever, low white cells, neutrophils, platelets, and HB. So basically, she's pancytopenic. So what do you think could have caused the pancytopenia? That's absolutely correct. So methotrexate interacts with trimethoprim or septrin or trimethoprim by increasing the free serum levels. So trimethoprim increases free serum levels of methotrexate and decreases its excretion, which then results in toxicity. And therefore, we advise that you don't use these two medications together because it increases the risk of myelosuppression and nephrotoxicity. So if you have a patient who has who's on methotrexate and has a UTI, we'd suggest if you have to use trimethoprim based on the sensitivities, just withhold the methotrexate for at least a couple of weeks. You could always give them steroids for their inflammatory arthritis in that context, but just don't give methotrexate together with trimethoprim. And the signs of toxicity you might come across, patients, I've seen a couple during my time as a registrar. So things like myelosuppression, so pancytopenia, which comes on very rapidly, mucositis, so sort of like erosion of the mucosal lining around the mouth, hepatotoxicity, and kidney injury. So this is just a screenshot of some of the drugs that interact with methotrexate. You can always find this on the BNF or the Green Book. Right, so the third case is a 36-year-old female who presented with a rash on her legs and bilateral ankle pain for 1 month. She has a fever, and she's had repeated courses of antibiotics from her GP with no response. The rash isn't getting better. The ankle pain and swelling isn't getting better. So this is what the rash looks like when you examine her, and that's what her ankles look like. What do you think this rash is called? Right, in the interest of time, I'm just going to carry on. So this is erythema nodosum, which is commonly associated with certain conditions. So this is the last question on the poll. So do you mind just going and typing in your answer? I'll just activate the poll now. And then you could just say what you think is caused by erythema nodosum, what's associated with it. So we've got several votes for inflammatory bowel disease, sarcoidosis, yeah. Okay, so we've got 17 votes so far. Yeah, so it looks like the answers basically split. So half of you think sarcoid, half of you think inflammatory bowel disease, or both, and some people think rheumatoid arthritis. So some of the common causes of erythema nodosum is drugs, so things like oral contraception, penicillin and sulfonamides, systemic diseases, so sarcoidosis and IBD are notorious for causing this type of rash. Infections, so tuberculosis has to be on the top of your list, malignancy, and inflammatory bowel disease. So when you examine this lady, she had synovitis in her ankles and she had raised inflammatory markers and white cell count. And she had a chest x-ray, which looks like this. Do you see anything abnormal in that chest x-ray? Can you comment in the chat box if you think the chest x-ray looks abnormal?
Hilar infiltrates, hilar thickening by hilar.
Yeah, so bilateral hilar bulkiness, which can be like bilateral hilar adenopathy. So the differential in this case is very obviously sarcoidosis. Is there any further blood test that you'd like to do to confirm or check that this is sarcoid? Again, just type in the chat box if you can think of anything.
Calcium association with hypercalcemia.
Okay. Anything more specific for sarcoidosis? So have you had a serum ACE levels?
ACE has started coming through S levels.
Through. Okay. Yeah, brilliant. So ACE is one of the tests you can do. However, it's not always raised in patients. It can be up to 50% of patients don't have a positive serum ACE. So it's not a confirmatory test. So in this patient, because she had bilateral swollen ankles and this abnormal rash, we did a TB gamma interferon to make sure she didn't have like TB. And because of the hilar adenopathy in the chest as well, you can sometimes see that in TB. So it's always good to try and exclude that. We checked her CCP rheumatoid factor because she could have had rheumatoid arthritis. Her serum ACE, as I said, came back normal, and a chest x-ray, we've already shown what the chest x-ray looks like. So in this patient with bilateral hilar adenopathy, polyarthralgia, and fever, she does have sarcoidosis, but it's a special form of sarcoidosis called Lofgren syndrome, which tends to happen in about less than 10% of patients with sarcoid. It's a very mild form of sarcoid. It's self-limiting, usually gets better with steroids. So we don't really need to kind of be worried about these particular patients who get Lofgren syndrome. And you don't really need a biopsy to confirm the diagnosis. So just checking their, they've met the 3 criteria, i.e. the erythema nodosum, bilateral hilar adenopathy, and polyarthropathy is enough to diagnose them with Lofgren syndrome. And it's common among females, Caucasians. Biopsy is not necessary, as I've said, and has a good prognosis with spontaneous remission. So in our patient, NSAIDs didn't make her any better. So we gave her prednisolone, 15 milligrams a day for 1 week, and she completely, the symptoms completely resolved, and we managed to get her off the steroids. So in the interest of time, I'm not going to go through what sarcoidosis is. You could always read that up on your free time. But then just to remind you that you can have lots of extrapulmonary sarcoidosis manifestations, and it tends to be common in females in patients of Afro-Caribbean descent. So if you see somebody with, say, dactylitis, swollen joints, and abnormal skin rash, remember to think about sarcoid. So our last case is a 69-year-old man with a background of angst who has a history of a fall 3 days prior and presents to the ED with lower back pain. When he's examined, he has no focal neurology, but whoever examined him thinks he's slightly tender at L4, L5. He has an X-ray of his lumbar spine, which shows no fractures, and is referred to the medical team for pain control. But he is still complaining of back pain, but we can't see anything on the X-ray. So on the post-take ward round, the plan is for us to get the X-ray reported to exclude a fracture. The X-ray is reported by the radiologist, and there's no fracture seen in the lumbar spine. And therefore, he's discharged back to the nursing home with analgesia and told to basically have bed rest and start mobilizing when he can. But 4 weeks later, he comes back in and he's paraplegic. And this is what his spinal imaging looks like. So essentially, he's had displacement of the vertebrae, which followed a hyperextension injury. And that's around the T12 L1 region. But if you remember, we only imaged his lumbar spine because we thought he was tender around the lumbar region, but he was complaining of back pain ongoing despite nothing being seen on the X-rays at the time. An MRI scan was done because he was paraplegic, and it showed compression at T11, T12, And they thought maybe there's a bit of discitis, but that wasn't entirely clear. So that's one of the scary cases that rheumatologists have come across. And essentially the learning point from this case is that patients with angstbond who have any form of spinal trauma should ideally have imaging of the entire spine with a CT or MRI. And in particularly in this case, because the patient complained that he was still in pain, but we didn't see anything on the X-ray. We just didn't go high enough to look for the pathology. And you know that with angstbond, you get like stiffening of the spine. So they don't have that mechanism in the spine to allow for any changes in gradient or pressure, which would then transfer the weight from one vertebra to the other. So for him, he had trauma, he snapped some of his ligaments, the vertebrae got displaced. We missed that when he came into the acute take. That wasn't us, it was 10 years ago. But then obviously he came back and he was now paraplegic. So just remember, in patients who have things like ankylosing spondylitis, have a low threshold to examine, to image the spine extensively, and more particularly with sort of more sensitive imaging modalities like CT scans and MRI spines. And then again, just to summarize a couple of other things, any patient with inflammatory arthritis, please find out what medication they're taking for immunosuppression, and if that kind of changes your management plan, and have a low threshold to suspect septic arthritis in these patients. So we often get calls from orthopedics saying, oh, or from medicine saying orthopedics say this is not septic arthritis, but nobody has actually stuck a needle in that joint. So don't get into the practice of diagnosing it by seeing the patient clinically. Septic arthritis, you need a joint fluid sample to be analyzed under the microscope. And then finally, avoid trimethoprim in patients on methotrexate. So those are my references. I'm happy to take any questions, and sorry I've taken you above over time.